All right. Hello, everyone. Thank you so much for joining today. My name is Carly Gersberg. I'm a program manager here at the Training Institute. Welcome to our webinar today. I just have a few quick housekeeping items before we begin our content today. To send questions to the presenter or panelists during today's presentation, you'll just click on the Q&A button in the toolbar on your Zoom screen. You'll go ahead and type in your question or comment and then click Send to Staff and Panelists. And there will be a Q&A session at the end of our presentation today, so all of your questions will be answered at that point. If you're having any technical issues, please feel free to reach out to us. You can contact us via the chat feature, question feature, or by emailing us at tisp@allianceforhope.com. We are offering credits for today's webinar. There will be 1.5 hours of credits, CME, BRN, and MCLE credits for today. To request credits, you will need to complete the correct evaluation per your discipline that will be sent to you in an email after today's presentation. And this is mandatory to receive those credits. And then just as a friendly reminder, today's presentation is being recorded. So if you miss at any point, we are going to send out a recording after the presentation via a Dropbox link in an email. And that Dropbox will also contain copies of the slides and any handouts that are mentioned today. Thank you so much again for joining, and I'll now turn it over to our president and host today, Casey Quinn.
Thank you, Carly, and thanks to our entire team who's hosting this webinar today. We're very honored to have their support and to have our highly esteemed panelists joining us today. This is a historic webinar in many ways in an unprecedented time in American history. And we thank you all for taking the time today to be with us. I know Gail Strack, who is also joining me today, joins me in this appreciation for all of you. We know that with COVID-19, with the unprecedented things going on across the country related to the murder of George Floyd, that so much is uncertain, so much is challenging right now in all the professions represented on this call. And we appreciate you taking the time. This is a life and death meaning life and death event as well, what we're talking about today, with significant issues that we're hoping to address. So we thank you for your time. The title of this webinar today is 2020 Imaging Recommendations for the Patient Who Has Been Strangled. This is a topic that relates primarily to medical professionals that are in the business of making medical decisions about patients in the medical setting. But we know that we also have law enforcement professionals on this call. We have advocates. We have many outside the medical profession as well joining us today. Our specific focus in this webinar, however, is on the medical aspects of dealing with someone who has been strangled. Most of you know that this is a topic that we specialize in. We are the leading program in the country on this at the Training Institute. And this is a follow-up to a webinar done a number of years ago based on all the new research that we have and all of the expertise that we have gained that will be represented by our panelists today. Gail Strack, our CEO, and I will be hosting this webinar. Gail, thanks for joining us today and thanks for making this webinar happen.
Well, thank you, Casey. It is such an exciting day. I think people who know me know how excited I am because this is historical. We have a lot to cover, so I'm just going to keep quiet and say, let's keep on going.
Well, thank you. And thanks to our panelists who are joining us today, Dr. Bill Green, Dr. Ralph Robiola, Dr. Bill Smock, and Dr. Mike Weaver. Without a doubt, 4 of the leading experts in America on the topic of near and non-fatal strangulation. And all men that have been working with us for many years and train across the country, speak across the country, and in their own rights provide an enormous amount of leadership in each of their fields and organizations as well. So thank you, gentlemen, for each of you joining us today. The way we're going to begin this webinar is I'm actually going to ask each of them to make some opening remarks that will allow us to frame the messages that are going to be delivered from this webinar today in just a moment. But I do want to thank the Office on Violence Against Women at the U.S. Department of Justice for hosting this webinar and authorizing us to provide funding for continuing education credits for doctors as part of this webinar, which is somewhat unprecedented for the U.S. Department of Justice. But we very much appreciate Laura Rogers' support and Kevin Sweeney, our program manager, who is joining us on this call today. The background before our panelists dive in is that this is being put on by the Training Institute on Strangulation Prevention, which is a program of Alliance for Hope International. Gail and I are honored to lead the Alliance and very honored to be a part of the Training Institute. The Training Institute, really, the work has began in the 1990s with Gail Strack's early research that we'll touch on today. And then it became an official program of the Alliance in 2011 with a grant from the U.S. Department of Justice Office on Violence Against Women. We now provide fee-based training and training for OVW grantees across the United States in the handling of near and non-fatal strangulation assaults. Our goals overall for the Training Institute are pretty clear. We're focused on increasing knowledge and understanding, improving practice, providing the best possible approaches for dealing with patients who have been strangled, and obviously increasing offender accountability and victim safety both in the work that we do. Men who strangle women are the most dangerous men on the planet, without a doubt. And the challenge for us in working with victims is many of them are suffering significant injuries, traumatic brain injuries, brain damage, long-term physical effects that play themselves out for the rest of their lives. And many of them are not getting the medical treatment that they need or the medical diagnoses that they need. So those are high priorities for us at the Institute. As I mentioned, this webinar was first produced in 2017. This is an update of that original webinar. We'll be talking a little bit about the journey of coming up with our current imaging recommendations. We'll be talking about the challenges of implementing those recommendations and what doctors in particular need to know in ordering imaging for someone who has been strangled in a domestic violence or sexual assault setting, in a human trafficking setting, in an elder abuse setting, in a child abuse setting. We'll be talking about the most recent research and then making some recommendations at the end of this webinar. As we start this webinar, we always like to give a shout out to our team at Alliance for Hope International. They're a very gifted and talented group of men and women who are passionately committed to making a difference in the world around social change and making a difference in the world for those impacted by violence, trauma, and abuse. I do want to also give a quick shout out. You saw Carly earlier, who's one of our program managers. We also want to acknowledge Emma Mattingly and Trish Middleton, who are on this call. They're the ones running this webinar from the backside. They have been organizing all of this, planning all of this, coordinating all of this. So thanks to our team for being behind the scenes for this webinar today. And though we have 4 of our esteemed faculty members putting on this webinar today, we have lots of other advisors and faculty members, doctors and nurses and police officers and prosecutors and judges, criminal defense lawyers, advocates, many other survivors that are also part of the Institute that are not able to share today, but are crucial to the work that we do. Probably the best context piece before I turn it over to our panelists to introduce each of their points of view is to honor and recognize Dr. Dean Holley. And it gives perhaps the best piece of context. Dr. Dean Holley was a forensic pathologist at Indiana University for many years. He did an enormous amount of work for the U.S. Department of Justice. And it was Dr. Holley who began doing this work with Gail Strack in the mid-1990s. And from the earliest of our work together was challenging us about imaging. And he was seeing the outcome of strangled victims when they died. He was doing the autopsies, thousands of autopsies, and he kept saying, we've got to be screening for these injuries before they die, because most of them we're not going to see if they live unless we do imaging, unless we do further assessments. So we give real credit to Dr. Dean Holley, who has since retired from his work as a forensic pathologist, but I believe, and I know Gail joins me in honoring Dean and thanking him for the beginning of all this. So let me turn this over to our panelists. I'm going to ask Dr. Bill Smock, who is with the Louisville Police Department in Kentucky and is also our medical director at Alliance for Hope International and the co-chair of our medical advisory board at the Institute, to first say hello and make his key points as we get started today. Dr. Smock?
Thank you very much, Gail and Casey. It's an honor to be here. I think at the end of today's webinar, you will agree with the quote that's on the screen that given our current state of medical knowledge and the morbidity and mortality associated with a missed arterial injury in the neck, it is malpractice not to order the screening CTA in the strangled patient. We will give you the foundation of what that recommendation is based upon. You will see a new recommendation coming out. We updated the last one in 2019. One for 2020 will be on the way out. We're going to look at some of the medical literature, but I want you to understand what are the risks to the arteries in the neck when you are strangled, even without visible external trauma. I'm also going to give you two faces to put on in the context. When you have a patient that's had an injury and you can put a face with a name, it really means a lot to those treating medical professionals, including patients who were strangled 6 days prior to coming into the emergency department and got a CTA at that 6th day and had a life-threatening injury. That if you looked at the external aspects, the outer side of her neck, she had 0 visible injuries. But what is more important is part of this journey, we have nurses and police officers who are on the front lines. And when they have a patient who is strangled and who meets the criteria for getting the CTA, even if a physician says, no, I don't think they need it, these two cases, these law enforcement detectives went the extra mile to make sure that the victim got the CTA, and what they found was they both had dissections. And you'll understand why we think the CTA is the gold standard, because of how easy it is to get in every emergency department across the country. And then we also want you to understand what are the risks if you fail to get that screening CTA. What are the risks to the patient, or the hospital, and what are the risks to the treating medical provider?
Thanks, Bill. And Dr. Bill Green, thanks so much for joining us, the medical director at the California Clinical Forensic Medical Training Center in California, very involved with the California DA's Association, and works with us all across the country and around the world. Dr. Bill Green, thanks for joining us today.
Thanks, Casey and Gail. It's great to be here. I also am honored to be part of this effort today to educate everybody about strangulation and how it needs to be handled in the emergency department. There is some new data that's come out that's really on point for the issue about the risks and what needs to happen from a screening standpoint in the emergency department that I'm going to talk about in a little bit more detail later. One other thing is that, as Casey mentioned, I work closely with the California District Attorneys Association, and they are just about to publish the 2nd edition of their manual on strangulation prosecution. I wrote the medical chapter for the 1st edition of that back in 2013, which many of you may have seen. That chapter has gone far and wide as a general medical overview. And I'm happy to report that the 2nd edition is just about to come out. Should be probably the end of June. And I rewrote that chapter, and it's much expanded. And also this chapter has references. So look forward to that future. A little bit later, I want to touch on MRIs for strangled patients, because there was some initial information about that. MRIs still have a place, but not nearly as an important role as CTAs do. We'll talk about that later. Most of the time, I want to talk about a paper by Zuberi and company, which came out in May of 2019, which is a very important study because it really gives us important data about the risk and the importance of CTAs in patients who have been strangled. So we'll be talking about the Zuberi paper, which unfortunately has been misinterpreted in some ways, when in fact it really is good news for us from a scientific standpoint. So we'll be talking much more about the Zuberi paper a little bit later on.
Thanks, Bill. And Dr. Ralph Robiola, thanks so much for joining us. Ralph is the chair of the emergency department at UT Health in San Antonio, Texas, after working many years in Philadelphia, and has been part of our faculty for more than a decade. Ralph, thanks for being with us today.
Thank you, Casey and Gail. I'm pretty glad to be here. This quote, if anybody has been to any of our programs, I've used it quite a bit, that it's more common and potentially lethal than you think, and getting the facts and guidance that you need to take care of the patient can really help make a difference in the care of that patient. I'm going to stress that the history of the strangulation and what happened is probably the key to knowing who you're going to image and who needs evaluation and treatment. Ask and look about signs and symptoms. Things that you may not have realized are important in somebody who's been strangled. And we'll talk a little bit more about them. And going to stress, like everybody else is going to stress, that CTA is important as it diagnoses the life-threatening vascular injury, but can also give additional information on the soft tissues, the laryngeal and tracheal structures, and the bones. So as a imaging modality, it really gives you a big bang for your buck.
Thanks, Ralph. And then Dr. Mike Weaver, who's the medical director at St. Luke's Hospital Sexual Assault Treatment Center in Kansas City, Missouri. Mike, thanks for joining us today.
Well, thank you both, Casey and Gail as well, and I'm honored to be here. As you can see on my first slide here, Siever Koop said that violence was a public health problem back in 1984, and it certainly resonates today. We're talking about the importance of evaluating this, and it's critical in this day and age, especially around CTAs. I'm going to focus some comments specifically on the financial aspects of imaging. What are the costs involved? Who's responsible for payments? And hopefully give you all some alternatives and some options in order to get to the cost of what we're considering the gold standard, doing a CTA evaluation for the patients who've been strangled. The second focus item for me is to talk a little bit about screening for blunt vascular injuries. And we all know that there are costs involved. Should you have a screening tool? How effective is that? And what's the downside of not doing it? We talked about the risk, and certainly in terms of stroke care, there's a cost that we pay in society if we miss this injury. So thank you.
Good, Mike. Thanks for joining us today. And it's my honor to now turn it over to Gail Strack to talk a little bit about the context of this journey that has brought us to where we are today. Without a doubt, without Gail's leadership at the Institute and without Gail's early research in the 1990s as a prosecutor that went on to be published in the Journal of Emergency Medicine, I don't think we'd be here today. So Gail, thank you for your leadership and for joining us today.
Thank you, Casey, and thank you to all of our panelists who are with us today. As Casey said when we started, today is a very exciting day, and it's a very important day for us at the Institute. Close to 25 years, we've been advocating for victims who were strangled, mainly because we missed it. In the next slide, you will see the two teenagers that changed my life forever. It was back in 1995 when both of these teenagers had called the police to report that they had been choked. Neither case got prosecuted, and each one subsequently was murdered. And that was a big moment in my life, because no one ever wants anything bad to happen under their watch. And at that time, Casey put me in charge of the Child Abuse and Domestic Violence Unit. So we set out to try to understand why and how did we miss it, because each one of these girls said that they had been choked, and neither case got prosecuted because we thought if there was no visible injuries, they were fine. And there was a big myth. And today we know that there are a lot of myths. So we dedicate this to Cassandra Stewart and Tamara Smith, two young teenagers at the time, two young mothers at the time. And what I'm going to share now is just a little history to put this into context, so this way you can understand why this is so important, because I think today we will all be very clear that the debate about imaging is now over. Dr. Dean Holley, Dr. George McLean, and Dr. Ellen Tolliver were the first ones to really help us understand the lethality and seriousness of strangulation. It was Dr. Ellen Tolliver in particular who said, Gail, the study that you all did at the San Diego City Attorney's Office is important, but unless it gets published, change is not going to happen. Because in my mind, all I thought we needed to do was just share the information. But what I realized in this journey, that publication, research is critical to making changes. I also want to thank Dr. George McLean, who was one of the leading authors in this particular article. As Casey pointed out earlier, Dr. Dean Holley said, you can strangle someone to death and not leave a single external mark. Strangulation victims are going to have internal injuries, and the only way to find that out is an autopsy, because people used to think if you were strangled, you were dead, and if you survived, you were fine. So it was those three doctors that put together the very first protocol on what we should do when the victim does seek medical attention. And I thought we were done, because Dr. Ellen Tolliver said, if you publish it, things are going to change. But it didn't happen that way. We had a group of individuals who went to our training, and they made those changes. But we didn't get national implementation. And then something else happened. And it was an important, again, turning point in our journey, where some research came out. We call it the Christie article. Everybody in this world knows about it. It came out in 2009. And Dr. Dean Holley brought it to our attention. And when you get to the next slide, you'll see why we all kind of grabbed onto this article. Because as Ellen had said, you need the research in order to make policy changes. So when this article came out, they really focused on non-fatal strangulation. They were using the MRIs to determine those internal injuries, and our eyes were blown wide open because now we had that article. But I want to point your attention to what I highlighted in red, which blew me away. It said one of the conclusions of this study is that there are survivors without petechia and without loss of consciousness who showed severe life-threatening internal injuries when examined by the MRI. I don't know about you, but that's like a holy cow moment. Everything that we were saying about internal injuries, and you can't see it, and you can't rely on that to determine whether or not a victim needs imaging. So all of us were like pounding the pavement and say, let's get MRIs for victims. And then another big turning point happened after we ended up getting the grant from OVW. And thank you, OVW. We really appreciate it. We had a chance to meet the people that are on this panel, people who were committed to this issue, had dedicated their career to this. And I think it was at that moment when the power of we started to evolve. So the next important piece was actually trying to figure out the connection of domestic violence and sexual assault and strangulation and those internal injuries. And I had the opportunity to meet both Dr. Robiola and Dr. Green, who were simultaneously writing about this issue, and we were combining our efforts. In the next slide, you will see here, as Dr. Green already mentioned, we're very excited about this new chapter coming up. The first one that we did in 2013, we had the opportunity to kind of like download everything we had learned to that point. But in a couple of weeks, we're going to get the new updated article. And I would say definitely read Dr. Green's chapter. I think he went from like 10 pages to 80 pages. And it's all good. And as he said, he gave me one of my gifts, which he had a lot of references to it. So this is information we can all use. And as many of you know, we add that to our reading homework assignment when you attend the advanced course. But this slide is important to me as well, and it should be to you, because I think this is going to be your talking point. As I was rereading all of the articles that the doctors have cited to, I started to focus on a theme that came out. And each one of these articles have been also pounding the pavement to say, we need to have clear protocols. We need to have a national protocol. And our team here, the medical doctors, put together that protocol in 2016. And then in 2017, we did the imaging webinar. But now we're at this point where things have changed. We have more research, and we can do more. Another important turning point that is key, and we encourage all of you to do this in your community. We started as part of our grant to do more focus groups with survivors. And in each and every focus group that we have done, there are themes that have emerged. And we started to appreciate and understand the long-term consequences that victims were experiencing, things that we had not focused on before. Many of the victims were suffering from thyroid issues. They were suffering from traumatic brain injury. They also had strokes. A lot of the symptoms of strangulation mimic the symptoms of a seizure, which mimic the symptoms of a stroke. I just reread some of the stroke websites and facts from CDC. We believe that there are victims who are suffering a stroke at the time that they are being strangled, but we still need more guidance, and today is that important step. The next thing that was really key, because we thought this was just going to be implemented with our training, we saw a gift and an opportunity at the same time. The gift came kind of hidden. I ended up getting a call from a prosecutor, Audrey from Ventura. She's an amazing prosecutor handling domestic violence and sexual assault cases. Audrey ended up getting a call from a police officer who also went to training and realized that the victim, who was at the hospital, had suffered a very serious near fatal strangulation case. She had been strangled to the point of loss of consciousness. She urinated, she had petechiae. And unfortunately, the hospital or the medical providers at that time had not received the training. So we had kind of like a mini clash, because the police officer was saying, we need an MRI, we need an MRI. And the ER doc had not received the training and didn't understand why. So what we did is we all got together and go, let's send them all the materials that the doctors have come up with. We did, but you know, I'm an attorney and I'm not a medical doctor. So good news is that we had a couple of our doctors, both Dr. Green and Dr. Bill Smock, available. Dr. Green was able to contact the ER physician, and she ended up ultimately getting I think it was a CTA, and Bill will talk about this later. And ultimately we had some good results. But that was another turning point, because we realized that in the middle of crisis and this acute situation is not the time to try to change policy. So we do want to kind of think that through. And what did also come out of that is we realized we all needed to do more. And that's kind of this long journey to where we are today, is that we need to do more. But with the guidance that we have now with research, we could take it up a notch. With 1,000 people on this call, we could take it up a notch. We can definitely take it to the next level. So we reconvened everyone, and now Casey's going to share what happened when we brought everybody together again.
So out of the Ventura crisis, we really realized that this focus had to become developing an imaging protocol. We don't have the benefit of large clinical studies, but we had an enormous amount of data. We had many case reports. We had a lot of information to allow us to begin to move forward in this process. So we ended up kind of taking a series of steps. We convened an OVW think tank sponsored by the Office on Violence Against Women with our national experts in August of 2016. That was an amazing 2 days with a lot of really smart people working in this field, where we made the decision that we had to not only focus on research and education, but we had to focus on practice and protocols and procedures. It was very beneficial to have the San Diego County District Attorney's Office involved in that. Summer Stephan is the elected DA in San Diego, and she was even then working with Tracy Pryor to begin to think about this issue and what San Diego County should be doing protocol-wise. We'll talk a little bit more about that later. But that think tank was a crucial moment. And one of the things that happened in that think tank was a presentation of the first case study that we did as an institute in detail, where we looked at a case in San Diego where a nurse had been strangled and had not been imaged and had not been diagnosed, and a very zealous advocate detective did something about it. And out of that came then subsequent case studies that we've now done. So I'm going to ask Dr. Bill Smock to talk about 2 of those case studies, which from our think tank became very clear that in the absence of large clinical studies, case reports and case studies could guide us forward. And these 2 case studies are crucial to what we're presenting today.
Thank you, Casey. This is Tanika. Tanika is a 36-year-old nurse. She was strangled unconscious by her husband, the second time she'd been strangled in her 6-month marriage. She saw a detective, Dr. Sylvia Bella, with the San Diego DV unit. Sylvia, who had taken our training, tried to convince Tanika, you've been strangled, you were rendered unconscious, you could have internal injuries. Tanika said, hey, I'm a nurse, I don't need to go to the ER. She finally, on day 6, elected to go to the ER. Her bruises behind her right ear, that was really it. Fortunately, she was seen by an emergency physician who had had some training. Although on presentation, now think if you're an ER doc, you have a patient that comes in and says, I need an MRI of my neck because a detective says so. And in your history, she has no visible injury on her neck. She has no headaches. She has no neurologic symptoms, no incontinence. What are you going to do with that patient who looks perfectly normal, doctors? Does she need any sort of imaging or not? Well, this physician elected to order a CTA. He expected that because of her history, she didn't need an MRI, and I would certainly agree. And he put in the medical record, given her overall mechanism, which was bicep and forearm placed around her neck, he was concerned about a possible carotid dissection. So he said, I'll order a CTA of the neck to rule that out. He anticipated the CTA would be negative. He had already written up the discharge paperwork and was prepared to have her follow up with a neurosurgeon when he gets the call from a radiologist. And what the radiologist found were bilateral carotid dissection. Grade 1, meaning less than 25% flaps, one side greater than the other. But look at this, doctors. She had bilateral dissections. What do you think will happen if she develops a clot at that tear? She is at high risk for stroke at some point down the road. So how many physicians out there would have ordered a CTA in a patient who was strangled 6 days prior to presentation with no visible external injuries and no symptoms? This is the radiologist's conclusions. Bilateral internal carotid artery dissections with a luminal flap demonstrated on the left. That should be a wake-up call that you can have dissections, in this case bilateral, with no visible external injury. That is scary. And when you get that tear on the inside of your artery, the body's response is to form a blood clot to begin the healing process. But what can happen is that clot gets larger, and if that clot breaks off, what will happen? It will go to the brain, and now you've had a stroke. This is Tanika and her lifesaver, Tanika and Detective Sylvia Vela, who without Sylvia saying, Tanika, you have to go to the emergency department. You have to have imaging of your neck. Tanika might not be with us. She might have stroked. But thank you, Sylvia, for your work. You were a lifesaver. And this is the second case I want you to think about as an emergency physician. This is Cristina. Cristina is 50. She was strangled unconscious by her ex-boyfriend. She was also assaulted to the face. That's where the board-certified emergency physician in a large hospital concentrated. She had swelling of her face. He got a CT of her face and CT of her head, which showed a zygomatic arch fracture. And he let it go at that. Discharged her without a CTA. But again, we had a nurse and a detective in this large city who had been trained by the Institute, who told Cristina that you have to go back to another emergency department, and because you could have internal injuries. And if you look at Cristina's neck, what do you see? In this case, you actually see visible external trauma, not only contusions, you see florid petechial hemorrhage, and you see abrasions. So 3 days later, after the detectives and the nurse said, you must go back, and encouraged Cristina to go back, she did go back to a level 1 trauma center, University ED, where she was seen by the nurse practitioner. That nurse practitioner ordered the CTA, and in this case, Cristina had a grade 3 internal carotid dissection. Grade 3 means that flap can occlude up to 75% of the lumen. Again, a life-threatening injury that was missed by that first emergency physician, but fortunately caught by that nurse practitioner. But what these both patients have in common, both strangled unconscious, their lives were saved by the detectives who'd had the training, who convinced the victim to go back and get that CTA. So Lieutenant Teachman and Detective Cunningham from Oklahoma City, they actually received a life-saving award for their work with Cristina to make sure that she went back to the emergency department and got the CTA. Thank you, ladies. You saved their lives. So our challenge was, based on the research that we have, could we come up with a protocol that would save a Tanika or a Cristina's life? And looking at all the research, we went back, looked at more than 100 articles. looking at what patients actually had carotid dissections and what was the best study to determine how to make the diagnosis, but what was the history. So as we looked at that, we looked at practices from other trauma associations, and what we came up with was that the CTA is the best standard to look for not only the carotid dissections, vertebral artery dissections, but to also look at other injuries that might be visible, fractures of the larynx or the cricoid cartilage of the hyoid bone. And without, as Casey referenced earlier, without having a large database, which we don't have, we have to go for case studies. So we looked at cases, including from the martial arts, where we were having jiu-jitsu instructors who stroked. We having judo instructors who stroked, karate instructors or students who stroked. We looked at injuries that were induced by the law enforcement application of the vascular restraint, which also can cause life-threatening injuries. We looked at autopsy data. We heard from Dr. Holley, who said, I've got cases where a victim went to the emergency department, was seen and was discharged without a CTA because the ER doc said she was fine, and now she's on my autopsy table, a missed carotid dissection. So based upon all that, we came up with a collective guidelines for what should we do for these victims who were strangled. It was initially published in 2016. This is the update in 2019, where we added that if we have a patient who meets the criteria of this either physical findings or a history, that they should get an aspirin if their CTA is delayed en route to whatever hospital they are transferred to or present to, so they can have the imaging done. We also included medical references. And we came up with a list of potential studies because we hear from emergency physicians across the country. Well, what about if we do an ultrasound? Well, the ultrasound can't show us the proximal internal carotid artery, can't show us the vertebral artery, so we don't recommend a carotid Doppler. We have to have a test that looks at the actual vessels in the neck. So the CTA is the easiest to get. It's available at every hospital that has a CT scanner. MRA is actually as sensitive, and there are some benefits of having MRI and MRA because that shows us more soft tissue trauma. But in this case, we wanted to look for and rule out the presence of a vascular injury. This is the disposition. If we have a negative CTA, that patient can be discharged, and you can open up the patient's bed for the next patient in your waiting room. The photograph, this is graphic, but it does tell a story. This is one of Dr. Holley's cases. This is one of those women who presented to a major trauma center in a large city with a history of strangulation. The ER doc said, you're fine, go home. And now they're on his autopsy table with a missed carotid dissection. That is inexcusable based on the information that we now have. What is also interesting is, when do these patients present? Because you may say, well, this patient has no neurologic symptoms, therefore I don't need to do a CTA. Well, they will have a normal neural exam until the second or minute that they stroke. And when do victims with carotid dissection stroke? When does that clot break off? It could be a day, a week, or a month later. And what I've highlighted in the middle of the slide are 3 studies, just like Tanika, who were strangled in a domestic incident, who had bilateral carotid dissections. When did they present with their stroke? 3 months, 3 months, 6 months post-strangulation. So we have a window where we can intervene and get that CTA. What we know from the natural healing processes, when you have a carotid dissection, that most will heal within 12 months. So if you've been strangled and it's prior to that 12-month window, then consider getting that CTA, because they may have a dissection with a clot that's still sitting there waiting to break off.
We're going to go ahead and do a poll question. Thank you, Bill. We're going to go ahead and do a poll question. Carly's going to make this available to all of our attendees. We have 1,000 people registered for this webinar today. And the question is, has your medical facility adopted the Institute imaging recommendations? The recommendations that Bill just presented. We know that some hospitals have. We know that others have not. We know some are in the process, but we'd love our attendees to answer that question. You can go ahead and provide your answer in the polling feature of our platform today and answer yes, no, we are in the process, or I'm not sure. And those that are not medical professionals may not even know what your current medical facilities are doing. So that's a perfectly acceptable answer. We'll give you a couple of seconds here to answer, but we're trying to get a little bit of a gauge of how much progress we've made in getting imaging recommendations adopted by medical facilities in the United States around this whole imaging for the patient who has been strangled. And there are our results. It looks like we have a lot of folks who are not sure whether or not their local medical facilities have adopted. We have a good 10% in process. We're very encouraged to see that. We see 18% that have adopted them and 28% that have not adopted them. So thank you, Carly, I appreciate that. And obviously we have a long ways to go. It's why we're doing this webinar today, and it's why we're focusing so much on this very issue. When we first created these recommendations, we thought that this would be relatively simple and straightforward. We have all these case reports, we have these case studies, we have the literature. We know this is a potentially life and death injury. This is a potential injury that can cause a stroke and cause somebody permanent brain damage. It makes sense if there's any chance that somebody can end up with a carotid dissection or other major internal injuries, that we find out about it. We were somewhat naive, I think. Gail and I think both felt that this would not, we knew we'd get some resistance. We didn't know how much resistance we'd get, but we've gotten a lot of resistance, and a fair amount of that resistance now has been kind of organized in our minds. We have focused on really 5 major questions or challenges that have come up from medical professionals in particular, looking at these imaging recommendations and asking questions. So we decided to just take them head on, the 5 questions that we're talking about today. The first one is this whole issue around whether a CTA is medically necessary, or is it just that the prosecutors and the cops want it for forensic purposes? And the bottom line is, isn't there another way for us to go ahead and diagnose this by just a basic exam? Why do we have to have the CTA? Those kind of questions all spin together around this whole issue of why, or is this really medically necessary? And I'm going to ask Dr. Ralph Robiola to start that conversation by addressing that issue.
Thank you, Casey. And to answer the question you posed, no, a general history physical exam or just looking at somebody, you can't tell if they have a carotid dissection or an injury to their vasculature. So I wanted to take a step back from the imaging to say that the first step is really taking the patient's history, then performing the complete physical exam. And those 2 steps will really help you guide the need for imaging and who's going to be imaged in your emergency department. Next slide. I think the history taking is probably the biggest piece of it, because it has to be accurate and it has to be complete. It's not enough to just say that patient was strangled or choked. I think you need to delve into it and ask, what was used during the strangulation? What position was the patient in when they were strangled? Was there any upward or twisting motion of the neck? Was the neck pulled or strained in any way? Was it jerked? Was there violent shaking associated with it, or repetitive strangulation? Because we know that about 33% of strangled patients may report no significant signs or symptoms of their strangulation. But based on those history elements, you could determine that this was a severe enough strangulation with a risk of injury to the vasculature that you need to get imaging studies like a CTA. And using our guideline, we even talk about other signs and symptoms. Next slide. So the positioning, the movement of the neck can lead to injury potential. So you could have direct injury from the strangulation, injury to the trachea, the larynx, the blood vessel compression, leading to the neurosymptoms and petechiae, blood vessel injury, hyoid bone injury and fracture, neck bruising, all of those external signs. But you could also have indirect injuries. And here we're talking about the carotid and vertebral dissections. And a lot of this is due to shear forces on the blood vessel. And if you look at it from a mechanism standpoint, it's distraction and extension or flexion or rotation of those blood vessels that will cause that tear. And when we think of carotid dissection, we know it can occur from many other causes, such as chiropractic manipulation, amusement park rides where the head is flipped around or violently moving, car accidents. And we even see it in people who spend a long time overhead painting where their head is up looking at the ceiling and their neck is bent backwards, or people in hair salons when they've had their head back getting hair wash. Just that movement can be enough to cause a carotid dissection. Next slide. And I think it's Dr. Green's turn.
Yeah, if I may, let me just talk about this because I think you all have a pretty good sense at this point that one of our tasks has been to overcome a lot of myths and misconceptions that are out there, not just in the medical community, but everybody has misconceptions. So this is a slide that I frequently use about the myths related to strangulation. So no neck finding equals no strangulation. Absolutely false. No neck finding equals no crime. That's obviously a criminal justice context. Absolutely false. No neck findings, no need for evaluation. Absolutely not. And no neck findings, no medical danger. All of those are important myths that everybody who deals with a strangled patient should understand. The next one, Casey. And here's part of what contributes to the myth, and this has already been mentioned a couple of times, in the context of autopsies, but this is also true in the context of living victims of strangulation. Many of them will not have visible findings on their neck. And as part of my task of writing this new chapter that we've already talked about, I had a chance to really dig into the literature, and this is essentially what I found, is the absence of visible neck findings are extremely common. The median for all of these studies is 49%. Half of the patients that you're going to see that were absolutely strangled in a potentially lethal way are going to have a normal looking neck. And then this is some of the strangulation homicide data down here, again with some references. Up to 40% of patients who were unequivocally strangled to death. This is known because this was the cause of death by the autopsy. So there's no question about what happened to these patients. Up to 40% of them are also going to have normal looking necks. And then so again, this is, I think we're starting to go over some territory that has been covered, but it bears repeating, is that CTA has been extensively studied. There is no doubt, there's no scientific doubt that CTA is the best screening procedure to rule out a vascular injury. And I will use this abbreviation later, BCVI, blunt cardiovascular injury, which means blunt force injury to the arteries in the neck, which can be the carotid arteries or the vertebral arteries, the two sets of arteries that nourish the brain. Modern scanners that are 64 slices and above are considered the gold standard for this. And as everybody's already acknowledged, every emergency department is going to have a scanner. At this point, they're going to be modern scanners capable of ruling in or ruling out of. And as Ralph said earlier, I completely agree with this too. You get more bang for your buck. You're going to get a lot of information about other structures, bony and soft tissue in the neck, besides just the vascular injuries. Next one is Ralph.
Yeah, thanks, Bill. And Ralph, I'm going to ask you now to come back. I know we have gathered some of the best articles on this whole issue around medical necessity of CTAs, and I'd like you to just talk a little bit about those.
Yes, thanks, Casey. We have some 20 articles that we feel are the key articles around strangulation, and just some of the key points from them, and I don't want to take too much time, but if you look here from the Pervin article in '97, few cases of carotid artery dissection were diagnosed before 1980 due to the poor quality of the imaging. CTA really didn't start to take off until after 1980. Cerebral artery injuries are rare, but most likely underestimated because of delayed presentation and or delayed death. Underreported and under-researched by physicians by Clarat in 2004, and that asymptomatic patients need a complete medical exam. Internal injuries may not present themselves. From the Malik article, manual strangulation as a result of IPV should be part of the diagnosis of a stroke, especially in young women. Yen, strangulation poses a challenge because internal injuries can easily be missed. Yen, further 2 years later, there is a need for the forensic community to discuss and develop standards for the evaluation and forensic interpretation of strangulation injuries. And from Mayo, non-fatal strangulation, life-threatening assault due to the wide range of health consequences, no real specific treatment, but because of the possibility of brain damage, it's important. Conducting imaging is not a lengthy process. The lack of an adequate diagnostic procedure will lead to medical malpractice. This is just in 2009. At Christie, both in 2009 and 2010, imaging can detect neck injuries that cannot be seen during a typical physical and or forensic exam. Dr. Stupinski in 2010 did an article where he looked at the CTA data for carotid dissection, and he too concluded that it's the gold standard for dissection. Molasek, every patient should undergo imaging, focus on the arterial system, and CTA is preferred. Lakovo, fractured hyoid bone, once believed to be an extremely rare finding in a non-fatal strangulation survivor. Delayed death reports by De Paula. And this is the best quote, I think: the unsuspecting clinician is a greater risk. Going back to that, taking a history of what actually happened. NFS goes unreported and undetected in the ER. Sethi further says physicians play an important role in ascertaining various causes of injury and instituting appropriate interventions to help reduce its incidence. And Nazal need a high degree of clinical suspicion in strangulation cases. Aggressive screening is cost effective.
That's great. And thank you, Ralph, for kind of covering that. All of these resources, by the way, that we're talking about are available on our website at strangulationtraininginstitute.com or .org in our resource library. I do see some questions coming in, and I do want to say that we're going to keep time at the end to take some of your questions, have our panelists respond to your questions. So if number one question was, is it medically necessary to be doing a CTA? Probably the next big question is, we've received all kinds of feedback that somehow the risk of radiation is too great to be using a CTA in the strangled patients that we're seeing. And I'd like to ask Dr. Bill Smock to address that.
So there can be certain risks to a patient, particularly if they have decreased renal function, because you are giving contrast, but there are ways to get around that. You may even have a patient that is allergic to the contrast, but we can, again, get around that. You will see on the website, we do have protocols for the pregnant patient, but as Dr. Weaver said, the pregnant patient is no different than the non-pregnant patient. They can safely have a screening CTA to rule out the presence of a vascular injury. The biggest pushback that we get is, what is the risk? An ER doc may say, I don't want to cause this patient to have a thyroid cancer 10, 15 years down the road. So we went to the literature. What is the risk of thyroid cancer at some point 10, 15 years down the road? And it's really 1 in 13,699. That is so small. But then what is the incidence of having a carotid dissection if you are strangled? And it's 1 in 47. So let's do the math. The risk of having dissection 1 in 47, the risk of giving a patient a potential cancer 15 years down the road, 1 in almost 14,000. You tell me, physicians, where is the greatest risk? And it is in the patient that is right there in front of you. So we need to consider that, and don't let the risk of radiation years away cloud our judgment in getting the CTA in the strangled patient.
Thanks, Bill. The third of these top 5 questions that we have been asked is, who's going to pay for it? What's it going to cost? How can we afford it? And I'd like Dr. Mike Weaver to address that question.
Thanks, Casey. Next slide. So one of the things that we hear in the emergency room, especially from emergency physicians, is that they don't want to run up a bill and have a patient responsible for paying for the cost of what you hear us repeatedly saying now is the gold standard, a CTA. So here's a menu of different funding options for getting a CTA paid for. None of them are perfect, but they all have a role to play in getting the cost covered for your patient. Next slide, please. So actually, interestingly enough, our own Casey Quinn had the opportunity not too long ago to get a CTA, and this was not strangulation related, I want to point out, but he was actually shocked to find that he could get a CTA done for about $400 on a scheduled outpatient non-emergent basis. Now, obviously that doesn't apply to the patients that we're seeing, but clearly when we look at what happens in the emergency room, they can cost easily 3 or 4 times that much. Next slide, please. So we all know the commercials. That's great if you happen to have health insurance, that you can get that if you paid your deductible and get the cost of your CTA taken care of. If you don't, there's obviously coverage through Medicare, and there's coverage through Medicaid, depending on whether you meet different criteria. And one of the things I want to really emphasize to the emergency physicians is that whether this is going to be covered or not really depends on how well you document your medical decision making. If you just order a CTA and that's it, as opposed to I'm ordering a CTA to rule out the risk of a stroke, or I'm ordering a CTA to rule out the risk of a dissection, you're in a much better position to get that test covered by the insurance carrier than if you don't put that down. So I really want to emphasize that. That's something that's really in your hands. It's a powerful tool, but if you don't document it appropriately, then you will not get that covered. Next slide, please. So another option for you is crime victims compensation. And again, just like the commercial players, this varies across different venues in the country. Typically, I'll just share what we experience here in Missouri and Kansas. So first of all, the commercial payers are billed first. And then after that, there are a lot of different criteria that you have to meet. Typically, there's a cap. And again, this varies. You know, on the East Coast and West Coast, cost for all healthcare is much higher than in the Midwest. So you may have different caps depending on where you live. Other criteria, you must file a police report. You must agree to cooperate with law enforcement. There is a limit to the time that you can file. But typically, if you get crime victims compensation, it will cover you for that visit, and to a certain extent, any ambulance bills, pharmacy, lost wages. Again, this varies so much state by state and region by region. You may also have some of your costs recouped by court determination, depending on what goes on. So it may actually be ordered that part of your healthcare costs as part of the sentencing or the civil order to be reduced. The Department of Justice, and this again is nuanced. It depends. Obviously, someone in a federal prison will have their costs typically covered, but in state prisons and in local jails, it may depend on whether the patient is seen in the emergency room and dismissed back to the local jail or state prison, or if they are actually made an inpatient, and then hospital laws and rules cover that reimbursement. Special waiver. So, you know, I will say at our hospital, let's say you come in and are strangled as part of a sexual assault examination. So we will take all of that together and we will cover that cost. We feel that's part of our community responsibility as a rape crisis center. Your hospital may have other funds or foundations that help to pay for crime victims that are not covered through your state criteria. And then some counties actually have funds. So you just need to, I wanted to just let you know there are a menu of options that you should look into in terms of getting coverage for your patients that come in that you need to get a CTA.
And then, Mike, we're going to shift to question number 4 of these top 5 questions. So why am I doing a CTA if it turns out that the majority of the time they're going to be negative findings? You know, have I wasted my time and money when I'm doing this, and the likelihood of it being positive is relatively low?
Yeah, so what I've done, again, we've all done, is we've got a list of some sentinel articles in the literature, and I'm just going to go over a couple of them with you because, next slide, that this is something that we've been looking at for a long time. So you can see Denver has a very robust trauma system, and most of the early literature is all about blunt cerebrovascular trauma, not in strangulation. So we initially looked at that literature, and you can see back in 2005 that some of the articles we're looking at really is this cost effective. And I'm not going to read the whole slide to you, but the conclusion of this article, even back in 2005, yes, screening takes time, costs money, and may have low yield rate. And I'd actually put low yield rate in quotes, because back in 2005, we were actually thinking that the risk of blunt cerebral vascular injury was like 0.1 to 0.3%. You've already heard a little bit that number is much higher now since we're doing more screening. The third bullet here, early screening can prevent ischemic neurological events. The cost of long-term rehabilitation care and human life after a neurologic event is substantial. Next slide, please. Kay out of Hopkins 6 years later in 2011, and just again a couple of bullets on this slide, screening patients for blunt cerebrovascular injuries has been shown to increase the detection rate of this injury with subsequent treatment reducing stroke rates. In that particular study, stroke rates range from 1 to 11%. And the second to last bullet, the cost of a CTA was $10,000 per stroke prevented. And when you put that in the context of what it may cost to take care of a stroke victim, over $500,000. And of course, this is stratified if you're talking about a stroke victim that's in their 60s or 70s versus a stroke victim that's in their 20s or 30s. Clearly cost effective. Next slide, please. Okay, went on to say, first bullet here, when compared to not screening, implementing a strategy where CTA is used to screen patients at high risk for BCDI would decrease the stroke rate by 10%, looking at a savings cost per patient screened to society of $31,000. Next slide. So out of Canada. So this was another 6 years later, and he looked at the literature review at that time. And again, as I said, back in 2005, we were thinking the number of these sorts of injuries for blunt cerebrovascular trauma was around 0.1%. So now we're fast forward to 2017, and we know it's now up to 2.7% in institutions that do routine screening.
We've lost Mike's sound there, I think. Mike, I think you're muted.
All right. So for this study from Canada, they used a very broad screening criteria, and it wasn't really focused specifically on strangulation. And I wanted to leave on this slide because it really tees up the powerful information that the bills are going to talk about now, because we're even higher than the estimated risk factor that these early articles looked at, and it emphasizes the importance of doing the CTA.
Thanks, Mike. So the fifth top question that we have been dealing with, I'm going to ask Dr. Bill Green to dive into. How do we convince others to adopt these imaging recommendations? Why is this something that we can win the argument about, and what are the strategies that we should be using?
Have the next slide. Thanks, Casey. All of us on this panel have spent a lot of time talking to our colleagues, to talking to communities about the importance and the necessity of doing adequate screening on patients who have been strangled. These are sort of the general strategic approach when you get resistance in a community. The first thing to do is find out what that resistance is all about. Where is it coming from? Who is it? Is it the director of the ER? Is it a couple of ER physicians that aren't up to date on all of the information we're talking about today? Is it a county executive? Is it somebody in the authorization stream of who is acknowledging, authorizing, and paying for these studies? Figure out where the resistance is, because you've got to understand that before you begin bullet 2, which is to educate your and those skeptics can be in any discipline. They may be medical, they may be administrative, but you got to find out who they are so that you can talk to them and get the argument, the proper argument in front of them. We pretty much always have covered this next part about the two things that often come up, as already discussed, are the cost, the number of negative studies, and the radiation risk. I think the radiation risk is the easiest. For me, that is a non-argument. The risk is so small, it's minuscule, that it almost doesn't deserve, I mean, we can talk about it, but it's not a real part of the argument. The cost issue, as Mike has gone through in detail, is important. I want to add just one thing to that. And not only is it the cost of the stroke care that's going to be required for that patient. Mike makes an excellent point that we're not talking about people who are stroking in their 70s or 80s. We're talking about strokes that occur in young people. So the cost of their medical care for the rest of their life is going to be considerable. But please add to that the associated malpractice costs, which are in part financial and in part going to be very devastating to the individual who gets sued. And I think Bill Smock has teed this up a couple of times where he's talked directly to our colleagues in the emergency department is, do you want to be the one on the stand to try and explain why you didn't screen that 27-year-old strangulation victim who stroked and is now in care for the rest of their life? So add in to the financial costs and the personal costs, the medical costs as well. And this is a setup for things to come. The Zuberi article, again, which is, I think, a critical argument that really helps make the point, even though some of the things in Zuberi are superficially look disappointing in the argument. The reality is that Zuberi gives us best data to date doing widespread screening.
And we're going to talk about Zuberi in just a minute, but we do want to touch on a couple articles besides Zuberi, and I particularly want to ask Dr. Bill Smock to talk about this 2020 article in particular.
This is the most recent. This was published in the Annals of March 2020, where in Indianapolis, the Level 1 Trauma Center, they looked at using the Institute's protocol, and they actually did CTAs or MRAs of 5 patients and 144 CTAs. And what they found was the incidence of dissection, either in a carotid or vertebral artery, was 1.3%. So I think the takeaway point there is this is not as rare as we once thought. If we look at Zuberi and the incidence is more than 2%, and here it's more than 1%, what they did in Indianapolis based upon their findings was they endorsed, this is again a Level 1 academic trauma center where they have endorsed and are using the Institute's recommendations for CTAs in strangled victims.
Thanks, Bill. And now I want to ask Dr. Green to talk about the Zuberi article he referenced, which has had a lot of conversation going on in the medical community, and we think is both positive and negative. But I'm going to ask Dr. Green to dissect it for us, because this is crucial to get this right when you're making your decisions about CTAs going forward.
Thanks, Casey. Well, first, let's just review some of the basic pieces of the Zuberi article. They used 142 consecutive patients with a history of strangulation. And the Matthews study that Bill just talked about was a little bit different because in Matthews, those patients were CTA'd based on physician preference. Zuberi was different. Zuberi, by 142 strangled patients. And what they found, these were the initial interpretations by the first radiologist who read these CTAs, found that 6 out of the 142, or 4.2%, had vascular injuries. Because this was a study, all of those CTAs were read later by 2 board-certified neuroradiologists. The first radiologists were all board certified in general radiology, but not neuroradiology. So because this was a study protocol, all of them got reread later, so it wasn't helpful for clinical decision-making. But what those 2 neuroradiologists did was they came up with some different numbers. They felt that 4 of the 6 initially positive studies were in fact false positives. So they took 4 studies off the list of positive. They said, no, what you first radiologists saw were really. So now we've got, instead of 6, we've got 2 definitive positive vascular injuries. And here's part of the scary part of this article. In the reread, the neuroradiologists found that one of the studies that was initially read as negative actually contained a vascular injury. So now the final tally is 3 out of 142 patients, consecutive patients, had dissections. That's 2.1%. 2 of these were in the vertebral arteries, 1 was in the internal carotid. An important point here is that a lot of the discussion revolves around carotid arteries, which is appropriate, but don't forget the vertebrals, because those are smaller arteries. They contribute a smaller percentage of blood supply to the brain, but these arteries are at risk. And the at risk for the vertebrals, again, another point that's is stretching or twisting is the primary mechanism that injures the vertebrals, not direct compression like occurs more commonly in the carotids. So think about that. Back to Ralph's point, the importance of getting a history. Was your neck stretched, twisted in any way? That is an essential question in the history. Next one, please. So there were serious problems with this study. One was the quality problem. That had to do with the issue about the radiologists not getting it straight within their own group. That's a longer discussion we don't have time for now. There was a serious procedural problem, which I'll talk about next. The study came up with important findings, very important findings. Their conclusions are what is disturbing and has caused much of the controversy. We're going to dissect those again in a minute about the consequences. So here's the procedural problem. These authors used part of the Institute's protocol for screening, our recommendations and guidelines, without attribution to it. The details are probably less important, but this was clearly, at best, inadequate peer review and potentially scientific misconduct, that they didn't actually quote us and attribute this to the Institute. Now, here's the part that's starting to create the disturbing conclusions and the discussions about this. And again, I just plucked out some of the key phrases out of and these are quotes. Vascular injuries are exceedingly rare, the authors felt. The study in a screening protocol had limited diagnostic yield. The clinical threshold, they opined, for CTA should be increased. The bottom line is their conclusion was we're doing too many of these. We're getting too many negative studies. They brought up the issue about the thyroid gland and how it's radiosensitive and the risk of cancer. We've already dealt with that one. They also acknowledged that a positive vascular injury could not be clinically predicted by history and physical alone. The most detailed history, the most complete physical exam is not going to answer the question, who is at risk and who is safe to go home without a CTA. They ask for predictive validation of clinical prediction rules in this population. Well, that's code for saying we need more data. And we all agree with that. We need more data, but they left us hanging in terms of who should get it and who should not. So here's what we're hearing from around the country, all of us, and not just the four of us that are on this panel, but our colleagues and friends around the country. We're starting to get feedbacks from emergency physicians that they're either getting pushback from their radiologists. When they order a CTA in the context of strangulation, they're either getting a turn down or they're getting a discussion about, wow, come on, do you really need this or not? You know, that kind of thing. And in some situations, these patients are not getting the scans. Maybe due to radiology resistance. It also may be due, as we've already talked about, is to inadequate knowledge base on the part of emergency physicians. Next one. So let's look at what's not in dispute here. What's agreed upon in these issues? Strangulation is common and it can cause vascular injury. That's the BCVI that I talked about, stroke or death. Agreed. Yes, vascular injury is infrequent. In this study, it's 1 in 47. Is that really exceedingly rare? I don't think so. The vascular injury often starts without symptoms or findings. This is critical. And the grid that Bill Smock put up that showed the 3 patients who were delayed between the time of injury and the time of stroke were 3 months, 3 months, 6 months. This is the latent period. This is the silent period where the injuries occurred, things are happening, but they're not giving symptoms, they're not giving findings. This is our clinical opportunity to screen, diagnose, and then prevent the stroke. The good news is that if we diagnose this early, before it creates stroke or other neurologic issues, we can prevent it safely with oral medication, which is usually antiplatelet therapy that's safe, effective. It does carry some risk, but again, you balance the risk of the medication against a possible stroke and the argument goes away. CTA is the gold standard, we know that already. Comprehensive history and physical can't predict it, we know that. And we all agree that we need better data if we're gonna somehow figure out who can we safely send home without a scan. We don't have that data. Next. So here's some of the flawed logic. I think some of this you're already going to anticipate based on what I've already said. But here's what they did. The authors of this paper focused on decreasing the number of negative CTAs instead of looking at patient outcomes. That is a critical critique and criticism of this argument. These were academic radiologists. Now, I'm not taking anything away from the fact that these guys are smart radiologists, but the important point is that from their perspective, they're not in the emergency room seeing these patients. They're not making clinical decisions about these patients. They're looking at their data, and that is, in my view, not appropriate. They're not looking at patient care. And they focus too much on these theoretical risks, the radiation, the cost, and so on. Okay, again, a quote from them: limited diagnostic yield, vascular injuries are exceedingly rare, so don't test every strangled patient. That's the message. If you don't read this paper critically and understand what's in there, you could come to the same conclusions that they did. Well, it's really rare. We don't need to test everybody. Well, 1 in 47 is not exceedingly rare. That begs the next question. Okay, if we're not going to screen everybody, then what's the acceptable miss rate? If we're not going to screen everybody, we're going to miss some. So what's acceptable? Well, I think the plaintiff's bar would have an answer to that pretty quickly, and that answer would be 0. And from a clinical standpoint, it should be 0 for us as well. This is a sometimes silent presentation of a deadly or life-changing disease that we know we can easily diagnose and we can, in most cases, easily treat. 0 should be our standard for what we're going to accept of patients who are strangled to not be adequately evaluated. I think the next one, I think we can go ahead. I've covered those. The good news, again, this should be anticipated. You know, as we've all talked about already, we as a committee, both as a committee, but also as individual practitioners in the emergency department, have looked at this and struggled with this for a long time. And the situation is clear. This has to be an abundance of caution approach. Yes, we don't have all the answers. Yes, someday we may have adequate data that we can safely eliminate some patients from having to be scanned. We don't have that data now. So until we do, we got to scan everybody. And here's the irony for me is that the Zuberi authors you know, they're worried about we're doing too many negative scans, we should raise the threshold, we shouldn't scan everybody. The reality is they proved the concept of screening. They screened 142 consecutive strangled patients. 3 of those patients had vascular injuries. They didn't give us data about follow-up, but presumably when those patients were identified as having a vascular injury, they were properly treated and probably did not have bad clinical outcomes. They probably did fine, just like Tanika did, that we talked about earlier. So it's clear to me, I think the argument is, especially if you clinicians are out there and you're confronted with colleagues in your own department, or you're confronted with radiologists who have read the Zuberi study and say, no, this is rare enough, we don't need to scan everybody. You've now got the information.
Well, thank you, Bill. Thank you, and well said across the board. And I think that the findings of Zuberi, not their conclusions, but their findings, you're exactly right on. They prove the point that we have got to be doing screening, because the acceptable fail rate, the acceptable miss rate has to be 0. So that is the good news of this, is we've got data now saying 1 out of 47. Incredibly significant number of strangled patients who are going to suffer carotid dissection or something similar, some internal injury. But there's other good news too. And Gail, I want to ask you to just fly through some of that now before we wrap up today.
And I will, because I am seeing all those questions come in. So the good news is that those of you who have attended the training and have all this information, your hospitals are adopting these recommendations, and we're collecting those hospitals. So for those of you who said, my hospital has adopted it, please make sure that we have the name of your hospital so we can include you. I wanted to kind of tell you the other side of the Ventura story. Even though everything heated up in Ventura about imaging, MRI, CTA, Ventura also was one of the first ones out of the gate since then to adopt it countywide. And now Dr. Flossie, who was involved in that conversation, is part of our faculty and our team. And so good news is happening. We've also seen Camp Pendleton, the military getting involved, the Navy getting involved, and each one of our advanced course attendees, you are the change agents that have been implementing policy changes in your community. We had the chance to work with our friends in Australia, and after one training session, the radiologists were actually the best friends to the ER docs because they understood the literature, they understood the risk, and they're seeing cases as well. So we're seeing good things around the United States and also around the world. I like this one, it's my personal favorite. I've added it to our Dropbox. From New York, the Department of Health, they actually issued a statewide medical alert about non-fatal strangulation cases and the need for an extensive clinical exam along with imaging. So I like that one. I'm going to go even faster, Casey. You got to keep up with me if you're going to move these slides. San Diego County, I'm so proud of them. In San Diego County, they issued a county-wide alert, bringing this to everyone's attention. A side note, I had the opportunity to actually meet with all of the stroke specialists in San Diego. It was a unique opportunity. When I shared all this information with them and asked them, have you come across a patient who had a stroke? Of course, they all did, because that's what they do. Did you ask them about strangulation? Any prior intimate partner violence? And not one said yes. And so even this morning, when I looked up in CDC and went to all of the American Stroke Associations, and they listed all the reasons for a stroke, they gave you some really good statistics. You can get every 40 seconds, somebody has a stroke. Every 4 minutes, somebody is dying of a stroke. They listed all of the causes for stroke, and not one of those website pages listed strangulation or intimate partner violence. That is buried deep into the literature. So we also want to make another comment with this. Casey, you can go to the next slide. Is simply because it's not published doesn't mean it's not happening. And this is where I'm going to give my plea and also gratitude to Audrey Bergen from Maryland. It was back in 2008 that they attended one of the trainings and said, you know, we got to change it. And they did. And they didn't get any pushback from their hospital or their ER docs. But look at their findings. Look at 402 cases, because we're seeing some emails coming in, friends, about 149 cases is not enough. But here we've got 402 exams of strangulation with CTAs, and you got carotid dissections, you got fractured hyoid bones, you have edema, you have herniated disc, and you have symptoms consistent with strangulation, a stroke. And with respect to a stroke, there's another thing with Dr. Steve Campman in San Diego. I asked him, I said, doctor, you're the medical examiner of San Diego. How many people die every year in San Diego? And he goes, Gail, about 20,000. And I said, how many people do we know die of stroke? And he goes, yeah, here's the website, you can find it. And I go, how many people died of a stroke as a result of strangulation? He says, we're not asking that question. The only way a case gets to the medical examiner's office, and out of 20,000, he'll get about 3,000 suspicious deaths, is somebody has to identify it as a suspicious death. That's why all of you who are listening to this can play an important role in that. I'm going to the next one because I know we want to get to some of these questions. So our friends from Family Justice Centers, thank you for what you're doing. You're incorporating strangulation questions. You're like mini detectives looking for internal injuries from Shasta, from Tulsa, Fort Worth, Texas. All of them are listed here. They are identifying these cases and reporting it to us. That's another important piece. Please, 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 when you find out about one of these cases, let us know. And of course, Bill has talked about this. I'll let Bill just mention this one briefly because you were involved in this case.
Yes, there are still police departments out there that are training their officers in the use of vascular neck restraints. This is a case from Fort Wayne where during vascular neck restraint training, 2 officers suffered embolic strokes where a piece of plaque from their carotid artery broke off and went to their brain. So not only are there risks to victims, there are risks to officers who continue to train using vascular neck restraints. So departments out there, just be aware that your officers could stroke during training.
And under the category of it's not published, it didn't happen, what we're also finding as we're collecting case law on strangulation, emerging case law across the United States, we're finding these cases published in case law, not necessarily published in a medical research article. So I'll just leave it at that. We're going to give you a copy of this PowerPoint and you can come back to some of these points. Back to you, Casey.
We have a couple things, and I know we're going to go a little over on time. We will get to the questions here momentarily. We have now prepared for all of you who are advocating around these imaging guidelines. We have prepared a Dear Doctor letter that embodies a lot of what we're saying here today, that we are sending to doctors, to insurance carriers when they're declining to do CTAs or to pay for CTAs. I'm not going to spend much time on it except to say that that letter is now starting to move the dial because we feel as an institute that we have to intervene and challenge communities to adopt these imaging guidelines and to start pushing forward with complete patient exams and with imaging appropriate to our guidelines, because in the absence of that, people are dying. So we have that letter available. That letter has now caused, as I said, a variety of medical facilities and insurance carriers to change their mind. If you'd like to access that letter, it's available on our website, or you can reach out to us, and we're happy to provide it to you. As we're tracking malpractice cases, this letter is becoming more important. As we're tracking strokes and injuries to victims where it has been missed, this letter is becoming incredibly important to us. So please feel free to reach out, because the malpractice cases are coming. They have begun, they are in process, and there will be many more. Dr. Smock early on in this webinar made this statement, and that statement, Bill, if you want to make another comment about it, if some of our institute experts end up in a courtroom, this is what we're going to say.
Right. No, I think it's clear based upon the research, based upon the case studies, that you can sustain vascular injury when you're strangled. And if you as the emergency physician or advanced practitioner fail to order a CTA, shame on you, because the data is there. If it's really 1 in 47, whatever that incident is, it is not rare. And for the ER docs that think about in your trauma patient, how you automatically do your head to pelvis scan. And what is the incidence of a subdural or an injury or a splenic or liver lac? It is in that same area of that 2 to 3%. But yet, the standard of care says in a trauma patient, you're scanning you from head to pelvis. We need to be adding the CTA for our strangled patient.
And the verdicts are coming in. We're now tracking them. We're tracking them. There will be more. We have consumer attorneys that have been gathering data from our website and reaching out to us about this. So we only raise that to say that we would much rather see medical professionals do their work and save people than end up in litigation because they failed to do imaging that was able to find that injury.
Casey,
At very short order.
I'd like to jump in here too, because as we've been emphasizing about CTAs, and we're finding more the more we look at it and the risk, et cetera. Had a conversation with a colleague, Dr. Gary Gaddis out of WashU, that some of our colleagues know as well. And he's raised the question about EMTALA violation without doing a CTA, because we're supposed to be screening for emergent medical conditions. And very clearly, this is a potential emergent medical condition. So on top of all of these other things we've talked about and standards that we're talking about, I think we also need to be mindful of potentially violating EMTALA.
Thanks, Dr. Weaver. So this is the Institute's position at the Training Institute on Strangulation Prevention, that the CTA is the gold standard for assessing strangled patients. We do believe that that carotid dissection can exist. It can exist with no external visible injury. You can strangle someone to death with no external visible injury, which means you can strangle them almost to death with no external visible injury and still be causing internal damage that has no external evidence at all. And that's why we have decided to push on these imaging recommendations so hard over the last couple of years, because we know that we can save the lives of patients. Our advice to those of you in the field, whatever your profession, stay the course, push on this issue, push for imaging, push for the adoption of our guidelines, push for special training. We do grand rounds. We'll do anything to get this information to a medical community. Our docs are doing training all over the country. It's that statement, CTA is the gold standard and MRA is even better. I just want Bill Smock to make a comment about that before we go to our wrap up and go to our questions.
Right. Think about, we have to evaluate the inside of those blood vessels. The only way we're going to do that is some sort of vascular evaluation with contrast. CTA is the easiest. MRA will do the same and actually give us more information regarding soft tissue trauma. So either way is okay, just get it done.
We have lots of resources available to you on our website. I'm not going to spend much time talking about these because we have come to the end of our time and we need to go to spend a few minutes on Q&A. You can go to our website at strangulationtraininginstitute.com. We've got a 4-minute video on the importance of imaging that plays right off of YouTube. We've got a 2-minute video that explains why and when CTA should be ordered. Dr. Weaver and Dr. Smock have done an excellent webinar for us from 2019 that's available on our website, particularly related to the pregnant patient who has been strangled. I do want Dr. Weaver to just reiterate this. We have special guidelines now, our imaging guidelines for the patient who is pregnant and has been strangled. Mike, I don't know if you want to make a comment about that, but.
So I just briefly say that it's safe to do a CTA for the patient, for the infant, even if a woman's lactating, that the risk from radiation exposure, et cetera, is minimal, around 2 millisieverts. So you can feel comfortable with doing that examination CTA for patients that are pregnant as well.
Okay. We did want to acknowledge that we have access to materials from the San Diego County campaign that Chief Deputy District Attorney Tracy Pryor has made available to us. For those of you from communities that want to really get this word out and do a countywide public awareness campaign, these materials can be customized for your jurisdiction. We love this image. Only you decide what goes on your neck, and that's coming out of the Health Department of San Diego County, and they've made those images available to us for free. I do want to thank Ralph Robiola for his work with the American College of Emergency Physicians and his ongoing advocacy. We do believe this is going to be a more and more significant conversation for the American College of Emergency Physicians. Ralph, do you want to make a quick comment about that?
I'll just quickly say that we're looking at getting some information out into the ACEP literature, hopefully trying to get a research project through multi-center trial looking at other opportunities for training, and hopefully going to create like the sexual assault guideline, one on domestic violence, and actually put even more information around strangulation in it. So
great, thank you. Well, so those are our messages. The CTA, do not be fooled by no visible injury. All the research from Gail's first study that nearly half of all victims of non-fatal strangulation won't have any external visible injury. That's finding, as Bill Green noted, is still holding up in all of the research being done all over the country. We've emphasized the cost effectiveness. We just created our recommendations in Spanish to be available as well. I'm going to go ahead. I know our time is short. I think it's worth taking a few minutes though, Gail. If we have some key questions that we can address or answer, let's take a few of them before we wrap up today.
Well, we have a very good group. A lot of questions were coming right out of the gate, and a lot of them were answered. So that's the good news. But I'm going to be picking those that have not been answered, especially ones that I've never heard before. But this is an interesting one. What if ER doctors are concerned that having an adopted protocol increases their liability? Maybe we hear from Casey as the attorney, and then I would love to hear the other ER docs.
Well, I will take it from a legal standpoint, and that is having a protocol in place is not going to increase your liability. Now that protocols exist, now that guidelines exist, not having a protocol would be a consumer attorney, a medical malpractice attorney. That would be their happy place to come after doctors. If you have all this information and you've not adopted guidelines or a protocol, that's from a legal standpoint. From a medical standpoint, docs?
Yeah, this is Ralph. I would have to say that if you do have the protocol, where you're going to get in trouble is when you don't follow it. So I think having the protocol is somewhat protective in the ways Casey said. Not following the protocol is what gets you in trouble. And, you know, the other possibility would be being uneducated about a protocol. So should a case come to be filed, you know, the plaintiff's attorney is going to pull protocols from, you know, national references, local hospitals in the area, et cetera, et cetera. So I'm not sure that having the protocol puts you at any more risk.
Other docs, any follow-up comment?
I would just make a comment that this helps to establish better practice. So, you know, to have those available, it helps to educate everyone, and we want better patient outcomes.
And I'll just chime in quickly. We in the ER, we live with all kinds of protocols for all sorts of things. They're all geared toward better patient care. This is just one more protocol that helps create some guidelines about the most appropriate behavior. So I agree with what everybody else has said. You're much better off with the protocol, knowing about it and following it.
Good. Gail, you got some
Okay.
a few others?
Yes, we do. So Dr. Green, don't go away. I think you're probably the best one to answer this one. Actually, there are two. There's one comment related to the Zuberi article that 149 is not a big enough study to really rely on. Another comment was that the Zuberi article is so bad that you can't rely on anything, good or bad. Any comments about that?
Yeah, well, I got to agree. It's not a great article. It definitely has flaws. I only had time to go into some of them this morning or this afternoon. But the data is the data. It's the best we've got. The Zuberi study is the first published study that looked at sequentially protocoled patients, and that's what they found. Like many things, this should be the springboard to stimulate other researchers to do other studies, look at their own data. As Ralph said, we would love to get a big multi-center study going where we could generate large numbers that we could rely on. But I think the fact that despite its warts, came up with data that 3 of their patients got screened and found vascular injuries, and that is the truth. You know, they clearly had some quality issues about their radiologists with going back and forth about who has it and who doesn't, but they ended up with 3 patients that neuroradiologists agreed had the injuries, and that's the data we got to work with right now. And I welcome more data. I know we all do.
Okay. The other question came up several times having to do about children. And essentially it's saying is, where is the imaging protocol for children and what's your position on it?
Is that for me? Or
Any one of the doctors. I
well,
think
we all know that we have a pediatric committee that is working diligently to try and come up with consensus for imaging studies on children. And I'm not a pediatrician, so I don't want to step into their territory, but I know for sure that the issues are a little bit more complicated with kids.
I think Dr. Smock has jumped in.
And
and
again,
Ralph?
our committee, I know,
Okay.
is working on those.
What we found is the instance of dissections in the literature is certainly less in the pediatric population. We've looked at several different pediatric trauma centers, and we have one that'll do a CTA on everybody. I have one that'll do a CTA if you're 15 and older, and an MRA if you're younger. So I think it's hospital system dependent, but we're fortunate that the instance is less in the pediatric population. We don't have enough to get a protocol. Ralph?
No, I was just going to highlight some of those same points. And what makes it even sometimes more difficult in the pediatric population, when you look at the literature, they include a lot of different forms of asphyxia in their studies. So it's very hard to pull out pure strangulation data, because they often include, choking on objects or other forms of asphyxia, like suffocation and plastic bags, all that in the same study. So it makes it a lot harder.
Yeah, let's take a couple more questions quickly. We got to wrap up in about the next 5 minutes here. We're a little bit over, but it's important.
All right, I'm going to pick another one. I'm going to ask Dr. Ralph Robiola. One of our attendees says that they have a medical director who's actually writing up some protocols right now. And one of the recommendations is to include a 24-hour observation. And I know that in our literature, we've had that listed before, but what's the current thinking?
So I saw that question. I would hope that that is actually part of the protocol to include radiographic imaging. Just observing the patient for 24 hours isn't going to help you find any more injury or dissection. So hopefully it's part of a comprehensive protocol and package. Observation is tricky. It becomes expensive. It may not be covered if it's truly medically necessary. I'm all in favor of observation for people who can't eat or drink, need pain control beyond what you could give them to go home with. They have an unsafe situation to go home to, or they're intoxicated, or whatever reason don't understand what's going on, and you need time for them to recover. I think it's appropriate. But I think it may be a little bit overreaching to try to observe every patient.
Can I chime in on that one? The observation was basically part of an older scheme of how to deal with strangled patients. Observation may be useful for things like evolving airway injuries, which tend to surface in a much shorter time frame. But if you look at the vascular injury issue, the data from the trauma centers, the people who are injured and stroke later, and the slide that Bill showed from Choku, I highlighted this. A lot of the people that have an injury and are eventually going to stroke surface much later than 24 hours. So to think that you're going to use an observation period to mitigate the risk of vascular injury is really not appropriate.
Okay, Gail, maybe one more question, and we're gonna wrap it up.
Okay, then I'm going to take the last one, because there was a series of advocacy questions. And what do we do with a victim who says, I'm fine, I'm fine? How can A, we convince her to seek medical attention, and B, convince the untrained medical professional to provide some imaging? So I'm going to refer everybody to our strangulation assessment card. It was initially developed by paramedics for paramedics, but now after talking to Joyce from Sacramento, Joyce is an advocate. She's been giving this to victims when they seek medical attention, and she says it works. So what it does is describes the signs and symptoms of strangulation. It describes when you should be transported or go and seek medical attention. By the way, in California, it is the law. Every law enforcement officer who responds to a domestic violence call finds out the victim has strangled. They have a legal duty, to advise the victim to seek medical attention to ensure that there are no internal injuries. On the back of the strangulation card is advisal to the patient to help her understand how serious this can be and how bad things can happen with a couple of days. Also, there is a notice to the medical provider giving them information about what the doctors here, our panelists have talked about, the imaging guidelines. They give them kits. They're also available to talk to the ER docs. Just all you have to do is text us and we will get a hold of one of the doctors, and they're more than willing to talk to any ER doc that may have any kind of problem with imaging. The other one has to do with questions. What questions do we ask to really find out what's going on? I would refer you to our upcoming manual. There's an investigation chapter there. It has been reworked, also added more pages, and we have a lot more questions. We have top 10 questions, but once you start talking and asking questions and listening, you can ask many more questions than we used to. So Casey, we'll just leave it there. I can say this, that we will go back through a lot of the questions that we received. We will summarize any question that we feel that we haven't answered. We will do a supplemental. And I'm also thinking, Casey, this is a great webinar to put on our Hope Hub and break it down into segments so you can go back and revisit a particular point that one of our doctors made.
Thank you, Gail. Friends, we have come to the end of our time. I know we're a little bit over. Thank you to those of you that have stayed on. It is impossible in 90 minutes or 120 minutes or 5 days to do all of this and talk about all of this and address it all. It's why we have 2-day courses and 4-day courses. For our upcoming courses, and we are doing courses now for communities virtually. We're doing courses in person starting in the fall again. Please reach out to us at strangulationtraininginstitute.com or .org. We are a resource for all of you. We're a resource for OVW grantees. And this is a complex area of medicine, a complex area of the law. We just saw this play out with the death of George Floyd in Minneapolis. That pressure applied to the neck was strangulation. Those hands behind the back, face down, was positional asphyxia. People are already having different opinions about what caused what and what's this and what's that. George Floyd had virtually, I doubt, any external visible injury, but he was dead on camera. He was pronounced dead later. He was dead at the scene. This is complicated. This is difficult, whether the victim is a victim of police conduct or the victim of a rage-filled man in a gender-based strangulation assault, because most strangulation assaults are gender-based. They are men strangling women across this country and around the world. But I want to thank our panelists. I want to thank Gail for her leadership of the Institute. I want to thank our team on the back end. Here is the information about CME. I'm not going to go through it except to say that none of us have any interests that need to be disclosed. We are honored to provide CME thanks to the support of the Office on Violence Against Women at the U.S. Department of Justice. You will be getting an email that will provide you with that information, whether you're a nurse or a doctor. We only provide legal credits in California, but California's credits are so extensive in their documentation that most other states will accept California MCLE so that you can obtain credits if you're a lawyer as well on this call. As I said, please make sure to complete the proper information in order to request credits. This webinar has been recorded and will be available to all of you. I know I joined Gail and our entire team in saying that we do this work to honor those who have lost their lives. I know every doctor and every nurse on this call does this work because we want to prevent the death of another woman. the death of another child. Every police officer, every advocate, everybody doing this work is trying to prevent this from happening. Many years ago, Gail and I made a promise to Cassandra and Tamara's parents that they would not die in vain, that we would do something to make sure that their daughters did not die in vain. It's my hope and prayer that today we have been faithful in part to that promise with the information we've been able to provide today. Our conference is coming up in September. It will be both online and in person, subject to CDC and health rules. If you want to join us, it's our whole world. It's camping and mentoring. It's adverse childhood experiences. It's strangulation. It's family justice centers. It's trauma-informed, hope-centered work available to you. You can get more information at allianceforhope.com. Our next advanced course, which is our comprehensive 4-day course, is currently scheduled for the end of October. Lord willing, we will do that in person in San Diego, subject to our partnership with organizations that assist us in that and subject to county health rules. Time will tell. I want to say, if you are not part of our world, if you want to join it, you can text the word Hope Giver, all one word, to 22828 to get on our mailing list for upcoming trainings and events for the Training Institute on Strangulation Prevention and other work. And finally, thank you to Laura Rogers, Kevin Sweeney, Neelam Patel, the whole team at the Office on Violence Against Women in the U.S. Department of Justice. You have helped to make possible something that will save lives in the months and years to come. Thank you to our panelists. Thank you, each of you, for joining us today. I know you have much to do every day in your life, and this mattered. So blessings on all of you. Thank you for joining us today. On behalf of the entire team at Alliance for Hope International and the Training Institute, God bless you and the work you all do.